But welcome everyone to the Special Populations Corps 2023 seminar series of the New Jersey Alliance for Clinical and Translational Science. Thanks so much for joining today's presentation. We are very excited to have Dr. Cynthia Santos of Rutgers, New Jersey Medical School with us to discuss her research on improving pain strategies in the emergency department. Before we jump in, if you have any questions during the presentation, please feel free to jump in, ask questions throughout. We'll also have some time at the end for any questions we didn't get to. It's my pleasure to introduce our speaker today. Dr. Cynthia Santos is Associate Professor at Rutgers, New Jersey Medical School and is triple board certified in emergency medicine, medical toxicology, and addiction medicine. She is the Medical Toxicology Elective Course Director and Residency Scholarly Track Leader, and she is on the International Committee for the American College of Medical Toxicology, where she is a course instructor for the Global Educational Toxicology Toolkit and acts as the committee's research grant leader. Dr. Santos completed her medical toxicology fellowship at Emory University in the Centers for Disease Control and Prevention, and her emergency medicine residency at Mount Sinai Hospital. Her specific interests include medical toxicology education, global environmental poisonings, toxicology surveillance, and addiction medicine, and she's currently doing research on the genomics of buprenorphine and the hospital outcomes of buprenorphine induction in the emergency department. We're very excited for this seminar and grateful to have Dr. Santos with us. So Dr. Santos, welcome, and over to you.
All right. Does it seem okay on your end?
Yes, now it's perfect.
All right, I'm going to share my screen now. Good afternoon, everybody. Happy Halloween. I'm going to talk to you about our newest grant on improving pain strategies in the emergency department. Using both like innovative pharmacological options and non-pharmacological options. And I wanted to start off by giving a foundation of our current work and our previous work and our previous SAMHSA grants. So let me see, I'll get rid of this. So this was a notice of funding opportunity for the ED-ALL grant, and we saw it last year, and I thought this would be an excellent opportunity for us to really try and prevent opiate use disorder, at least from the beginning, by mitigating excess opiate prescribing. So I thought this would be a nice way to really just stop the problem just from the very start. And just so you understand, the previous work that we've done, this is our third SAMHSA grant. Our first SAMHSA grant was called the Opiate Peer Emergency Navigation to Accessing Comprehensive Care and Engaging in Specialized Services. The acronym was Open Access, and this basically funded our ED Bridge Clinic and supported peer navigators to provide screening, breakthrough intervention, referral to treatment, and really enhanced our programs for buprenorphine initiation and naloxone kit distribution. Our second grant is still active. It's in its final year. It's the Expanding Buprenorphine Training to Providers. This was basically in lieu of the data waiver educational requirement, and it helps support institutions to develop their own buprenorphine training. And currently, we just started last month our ED-ALT, our ED alternative opioid for pain grant, and this is ongoing for the next 3 years. All right, so if I'm not sure how many of you guys are familiar with University Hospital. It's quite different from, I think, the other hospitals in the New York and surrounding area. We have higher rates of IV drug use as compared to other sites, and our population is overwhelmingly resource limited. It's a predominantly Black, African-American, urban population. And when we look kind of closely at people who had been engaged in our program for at least 6 months, we found that a large percentage, about a quarter of them, are homeless. Most of them are unemployed. Almost a quarter of them had no health insurance, and about a little more than half of them had some sort of history of incarceration or prison or jail experience. So when you look at
Cynthia, the Peer Navigator program itself, I don't want to slow things down, but it looks like it has a design that's a little bit more longitudinal than the ORP, because you're engaging people for 6 months. So you're engaging this complex population for longer than sort of many of the EDs. Is that the case?
Well, the SAMHSA GPRA survey tool required a 6-month follow-up.
Right.
So for all these SAMHSA grants, the standard follow-up should be 6 months. And for the most part, I think we really, tried to make that like the standard for all patients. Not everybody were engaged for as long as 6 months, but we really tried to at least meet that for all patients.
Yeah, I asked that because I think it's become an important question in these ED peer navigation programs that you've got this very complex multi-problem population, and people might get engaged in for a few months, and they drop out of treatment, they're back at risk. So what we're the kind of search for ways to support longer term supports for them. So that's really great to hear.
Yeah, thank you. And the reason why this is especially needed within in the Essex County area is because if you look at this data from like the New Jersey Department of Health and CDC, our drug overdose death rate is higher in the state of New Jersey than in the U.S. overall, particularly in Essex County. And 2/3 of the deaths were from an opioid. And Essex County had the highest number of overdose deaths in New Jersey. And heroin admissions more than double any other substance. Now, if you look specifically at our institution, so there's a large population of patients with pain and underlying opiate use disorder. By nature, we see a lot of patients who are have a lot of lived experience with trauma, or both emotionally and physically. University Hospital is the only public health designated hospital in the state of New Jersey. So that combined with the fact that we're a level 1 trauma center, we are a very busy hospital with a lot of underserved patients who are critically ill. And we accept surgical transfers from across the state, regardless of the patient's ability to pay. And many of these trauma patients have acutely painful conditions or chronic pain exacerbation that are complicated by their high rates of underlying substance use disorders. So if you kind of look closely at our providers and their previous training experience, that created a major service gap and barrier to being able to provide effective care for these patients. So there's a large number of providers at our institution who are not trained appropriately on medical medications for opioid use disorder, and especially have very little training in innovative pharmaceutical approaches, especially when you try and do culturally competent care. So if you look at our consults for addiction within our hospital, about half of these patients with opioid use disorder have surgical complications as a result of either trauma or intravenous drug use. And okay. Sorry for this hiccup. Hopefully it's okay now.
Yes,
We'll
looks
be
great.
patient, whatever it is. If you freeze, you just get back in.
Okay, just let me know because I'm not sure in real time if I'm frozen or not. I apologize for these interruptions. All right, so hopefully it'll be smooth sailing from here on out. Okay, so just to recap, many of the cases that we get consulted on are for acute pain, whether it's also from precipitated withdrawal or inadequately treated withdrawal. And many of them occur in surgical patients who have acute trauma related to pain and that's complicated by withdrawal. We do have a pain consult service through the anesthesiology department. However, oftentimes the residents themselves are not sure how to administer pain medications while simultaneously initiating like buprenorphine. And we do have addiction medicine faculty that are full-time physicians across various departments. We're a very multidisciplinary group. We're represented by emergency medicine, internal medicine, psychiatry, and OB-GYN. But, it's very difficult for us to provide, 365, 24/7 care. So, this can create a situation where you have patients who are complicated from a substance use perspective, from a pain perspective, who are not getting adequately treated because of lack of training. All right. So our first grant was the open access grant, which is basically funded our ED Bridge clinic. And we use peer navigators to provide a warm handoff to patients to go to our behavioral health center where they could go to get their first clinic appointment for MOUD. This supported both retrospective and prospective studies on the clinical outcomes and also quality of life outcomes for patients who were engaged in our Navigator program. So this is one of our earliest publications, and this looked at the impact of the Peer Navigator program on naloxone distribution and buprenorphine utilization. And let me just show you a figure from this publication. So when we first started in June 2018, we implemented a naloxone kit guideline. There was a mild increase in providers who were prescribing the naloxone kit, but it really increased more around the time we had the Peer Navigator program. Then COVID hit. So when COVID hit, our ED volume plummeted. We were getting mostly just COVID patients. So then that's why you see like the decline in naloxone kits during this period. As COVID, the first wave was improving and, there was less COVID and things came pretty much like back to normal. There was a steady rise back into the early fall of 2020 in our naloxone kit distributions. And something similar also happened with our buprenorphine administration. So we created a guideline for buprenorphine initiation. And then there was really not that much of an impact in terms of the buprenorphine administrations that were given by providers per month. Around the time the Peer Navigator program started, it really increased up to like almost 5 times as it was before we had our guidelines. But then COVID happened, numbers went down. After COVID, the first wave of COVID ended, our buprenorphine administrations went back up. So this kind of taught us a couple of important lessons. So the presence of a peer recovery support program can have an impact on provider prescribing of naloxone and buprenorphine kits. And that this impact seems to be greater than the implementation of guidelines alone. So this was important at this time. This was published about a year or so ago. It was the first that compared the effectiveness of provider adherence to formalized protocols for naloxone and buprenorphine distributions to the implementation of a Peer Navigator program. And we think the reason why this occurred is because the ED navigators possibly caused a change in ED culture. Their physical presence in the ED, their engagement with the medical staff kind of reminded the medical staff that, we should be trying to do this for all our patients that present to the ED as much as we can. And, their physical presence is more effective than just making providers aware of a guideline. So this was another study that I published that looked at the impact of clinical outcomes, in particular ED visits and hospitalizations, both related to opiate causes and all causes in patients who were engaged in our Peer Navigator program. And we compared the ED visits and hospitalizations the year before and after they were engaged in our program. And this is basically a breakdown of our demographics that I kind of went through earlier. They're predominantly African American. There's a large rate of unemployment, et cetera. And we looked at ED visits and hospitalizations 1 year before and after. And then this nicely demonstrates that pretty much for all categories of ED visits and hospitalizations, whether it's all causes or opioid-related causes, there was a significant decline within the year after they were engaged. They were all statistically significant except for the all-cause hospitalizations. There was a decline, but I don't think there was enough numbers there to reach significance. But the other categories, there was a pretty good improvement. And then another question I asked, what I wanted to kind of address was, are these improvements in ED visits and hospitalizations related to underlying differences in demographics? Are patients who have more social determinants of health needs more likely to have a lot of healthcare utilization? So we found that our EDPM program improves clinical outcomes, and it's less likely that the improvement is from the underlying differences in demographics. When we looked at all the different demographic and social determinant of health needs, we found that only phone and age met statistical significance, but when we look more closely at this, adjusted odds ratio was less than 1. So this likely was just an error because of multiple comparison testing and less likely to be a true comparison. And one of our residents also was interested in seeing how pain medications improved with engagement of our peer navigator program. And this kind of is a first study that looks at the use of pain medications with our navigator patients. And we found that a lot of patients were actually using buprenorphine itself as a pain medication. And the predominant medication that our patients were using were non-opioid analgesics. So, this suggests that this could be a future area where peer navigators can improve another clinical outcome by improving their choice of prescription medication or non-prescription medication for pain. So the lessons that we learned from our open access, our first SAMHSA grant, is that although none of the demographic and socioeconomic factors had a significant association with clinical outcomes, we found that patients who lacked phone, housing, and insurance had consistently increased ED visits and hospitalizations. But one way we can kind of address this in the future is seeing if our peer navigator programs can help address social determinant of health needs and perhaps improve healthcare utilization. Another thing that we learned is that our EDPM program improves overall health as reflected by the decrease in ED visits and hospitalizations from both all causes as well as from opioid-related complications. And when we look closely, we found that our EDPM program is particularly effective in decreasing opioid-related causes and with a 250 decrease in mean opioid-related ED visits, and we had a 433% decrease in opioid-related hospitalizations. And participants in our program also reported less opioid prescription pain use after enrollment in the program. So this is our second SAMHSA grant, where we basically created a module to train an eclectic group of residents and students from various disciplines, NP students, PA students, on prescribing MOUD, harm reduction, and we tailored this to various electives. We also did didactic sessions through core clerkships, and we created simulation videos, workshops, clinical rotations that were supposed to be relevant to the learner's specialty and training background. So, I mentioned earlier that there was a gap in awareness and training of healthcare providers across all specialties. So what we basically did to address this was create a training module that's supposed to be provider specific. And we used different resources like simulation videos, and we had modules on these major domains: MOUD basics, that we went over buprenorphine, methadone, naltrexone, naloxone dosing to avoid precipitated withdrawal, pain management, and also harm reduction and communication strategies with patients. So this was ingrained in various electives. So this is addiction medicine, medical tox elective, and internal medicine, community research elective. And we basically tailored the curriculum based on who the student was and what background they were. We also utilized PCSS PCSS is a provider's clinical support system. It's kind of through SAMHSA, it's kind of like a library of different resources from many different institutions. And I found PCSS lectures that I thought were relevant to a resident, if they were OB-GYN or an anesthesiology resident. I tried to pick like lectures that I thought would be interesting based on their provider background.
Is the Cynthia, is the review clinical scenarios column, is that interactive, or is it more the whole thing didactic?
It is videos. So the students watch videos of like a resident. They're basically students and residents who volunteered to be actors, and they watch the videos, and it was basically simulations of real life cases. So one example for the naloxone dosing was actually inspired by a true case we had when a patient had received a large dose of naloxone, and then they had precipitated withdrawal that led to like a autonomic instability. They had a heart attack, and they had a pretty bad outcome. So it wasn't necessarily interactive, but I think it's not didactic because it wasn't like a lecture based. They were watching a simulation video.
Okay, and you find that the engagement with that is good, that you don't need to find sort of more interactive ways of getting them into the material?
One thing I was thinking about doing this last year was I like the videos because it's true to life, but if there's a way to make the videos pause during the module and they can answer questions in real time as they're watching the video as a way to get engagement. The reason why this is supposed to be self-discipline, like, students doing it on their own time.
Right.
So I couldn't, deliver this lecture on a daily basis, but if I wanted to maybe this past year edit the video so that maybe in the middle of the video we have like a break and I'll ask a couple of questions relevant to like what they just saw.
Yeah, that sounds terrific.
So then when I looked at like their pre-test and post-test, one thing we also learned during this process is that the way you deliver these videos are incredibly important. Like, Dr. Crystal mentioned whether they're interactive. Another thing that I think is important is the platform that you use. So initially we were using RedCap. RedCap has the ability for students, if they want to take the pre-test and post-test at the same exact time. A lot of students, I think, just wanted to get the mandatory requirements out of the way. So in the very beginning, I noticed students had a very similar pre-test and post-test score because they were just trying to get the requirements done. So we switched over to Qualtrics, which made the pre-test before the module, and there's no way to fast forward through the module. And then after you watch the module, you can do the post-test. And once we, delivered it through this route, we found that there was a significant improvement in their pre-test and post-test scores. I actually just repeated the medical student training yesterday using, Qualtrics as a module. So hopefully we'll get like a better pre-test, post-test mean score in the med students. But if you see across the residents, the pharmacy students, NPs, PAs, etc., there was a good increase throughout these other groups. All right, and our current and our newest SAMHSA grant is, the ED Alt grant, and it's supposed to incorporate innovative strategies using both pharmacological and alternative pain management techniques. This is for 3 years, $1.5 million across the 3 years, and I wanted to go over our current ED pain guidelines. I think our current ED pain guidelines are actually pretty robust. This is just a summary table of it. If you look at the actual document, it's like 10 pages, and there are tables and it's divided up by etiology of the pain. So it's provider friendly because it's based on like the patient presentation. It gives you options for first line, second line, third line, the dosing, and things to be mindful about in terms of indications and contraindications. We also have regional anesthesia protocols and various blocks being done within the ED. The reason why I mentioned this is because one of the last cohort Maimonides in New York City, they use the ED alt pain grant to enhance their regional anesthesia protocols. We still have some work to do in our own ED, but we are doing some nerve blocks. So our primary aim of this grant is to develop and implement alternatives to opiates and reduce the likelihood of future opiate misuse. So, to do this, we need to consult with local and outside experts across various disciplines, whether they're ED provider, psychologists, other health or clinical scientists. And we need to review and implement evidence-based strategies across various groups, across racial, ethnic, and cultural groups. We also need to incorporate evidence-based practices and looking at existing published literature that might predispose providers to have biased approaches that could be potentially influenced by patient demographics, social determinants of health, and other behavioral health conditions.
Cynthia, could you talk a little bit about the potential and limitations of buprenorphine as a itself as a pain management strategy? Because there's been a lot of discussion about it, but it's kind of a complex question when you have, for example, acute surgical pain or trauma pain. But just talk to us a little bit about those issues.
Later on in this slide, in this presentation, I have a couple of slides dedicated to that, but I'll just the basics right now. So IV buprenorphine was approved by the FDA in 1981 to treat pain before sublingual buprenorphine was created to treat opiate use disorder and withdrawal. My department chair likes to comment that when he was a resident, he was using IV buprenorphine in the ED to treat pain. It kind of came out of favor, and full opiate agonists became like the preferred medication, and hence the opioid crisis that everyone all knows. That being said, I want to bring IV buprenorphine back. I do use it to treat complicated withdrawal. So patients who have intractable vomiting and not able to take sublingual buprenorphine, patients who are too delirious to follow commands and keep something sublingually. I've been using it more and more for these patients. I do moving forward, want to use IV buprenorphine to treat intractable pain, especially in patients who are already maintained on sublingual buprenorphine. I think the main drawback or concern about using IV buprenorphine is causing precipitated withdrawal. But if you have a patient who's already maintained on sublingual buprenorphine, you already have a good test that they're not going to go into precipitated withdrawal. So let's say if a patient's admitted and they have acute pain, they tolerated sublingual buprenorphine well, and they're still having pain that's independent of their withdrawal symptoms, then I think we should be using IV buprenorphine for these patients.
And then what happens when you discharge them? Like what do they get sent home with?
So then we could do macro dosing with sublingual buprenorphine for pain.
Right.
The depot injections that we use buprenorphine for, they're not really effective for pain. They're really more for like opioid use disorder, mitigating cravings, etc. But one potential strategy is, macro dose, like doing large doses of buprenorphine. So it could be like an 8 milligram TID dose or 8 milligram, like 4 times a day dose to treat pain. But at least in the ED setting, oftentimes we have to rely on opiates for patients who have acute severe pain that's not mitigated well using our normal non-opiate strategies. Like, if patients are receiving like the kitchen sink for non-opiate medications, like, NSAIDs, Tylenol, muscle relaxants, even nerve blocks, etc., and they're still having pain, instead of us going to opioids, we should, I think, use IV buprenorphine for this. So I'm gonna develop a guideline to have this written down, and that way providers feel more comfortable doing this if there's like, concrete written guidelines. But this is something that I'm going to address this coming year. It's going to be part of the agenda for this grant.
And
And
are there data on the macro dosing with buprenorphine, what these curves look like with respect to, well, there are two questions with respect to ability to pain control, because, you know, we have this sort of, some people consider it a rather artificial cap of 24, and some people, and there's literature that in the fentanyl era, 24 may not even be adequate, and maybe we should be thinking about 32 for some patients. But what happens to both the ability to prevent craving in, you know, when fentanyl is around, and prevent overdoses, and also the profile in terms of chronic pain that people might have? Is there data on that? Is there like a ceiling effect?
there is a ceiling effect for CNS depression, respiratory depression, and euphoria. I don't think there is a clear ceiling effect for analgesia. So that's why I think it's important to utilize macrodosing, especially if it's safe.
Yeah, I've heard this assertion that the ceiling effect, you know, you may have a ceiling effect for respiratory depression, but you might not have as much of a ceiling effect for pain, in which case people who might have been chronically prescribed full agonist opioids might be able to manage longer term on buprenorphine.
No, I wholeheartedly agree. I think providers need to feel more comfortable using buprenorphine. I know there's a lot of fear from providers that they're going to cause CNS or respiratory depression, but we know it has a very safe profile in patients who have opiate disorder. They're not opiate naive. You might have these concerns in opiate naive patients, definitely in pediatric populations, but for our population of adult patients with opiate tolerance, I think buprenorphine is a very safe medication.
Great.
So, besides buprenorphine, other strategies I want to implement in our ED is using nitrous oxide, inhalational nitrous oxide, and other pain medications that are less commonly used, like magnesium. We use it for migraines, but not necessarily for other causes of pain, and really supporting more enhanced regional anesthesia protocols. In addition to using our pharmaceutical approaches, I wanted to start implementing non-pharmaceutical approaches. So, the ED is loud, it's chaotic, it's busy. It's hard to adequately do meditation, do cognitive behavioral therapy in the ED, but we could do something that I actually do when I work in patients in the pediatric ED. I use distraction therapy. When I have a painful procedure I need to do with a patient, I sometimes ask them, what do you want to watch on YouTube? I give them my phone, I put on a music video or something that they can watch just to distract them from the pain. So I want to start doing this kind of in a more, robust way by having peer navigators approach patients and talk to them about music therapy. We can provide noise canceling headphones. That way, the ambient noise can be dimmed down and they can kind of listen to a music playlist. We can have playlists that are patient generated or playlists that are referenced or that can help address patients' cultural backgrounds, language backgrounds, to really try and, I think, provide culturally competent care. Another thing that we could do is use virtual reality lenses to kind of help patients get distracted from their acute pain. And then I want to utilize peer navigators to help patients kind of educate them on these sort of modalities, introduce the topic of meditation and breathing exercises to them while they're in the ED, and then provide them with community resources where they can continue to get engaged in these treatments within the community. So, our second aim is to support the identification and intervention of opiate use disorder among these individuals presenting with pain. So, I want to emphasize team-based care approaches. So we're going to utilize peer navigators to do what they normally do, provide screening, brief intervention, referral to treatment, facilitate linkage. But in addition, I want to also have them counsel patients on these ED alt techniques. I also want to partner with IT specialists and our ED pharmacists to improve the way we place orders for our patients. We can develop a clinical decision support system that can incorporate our updated paying guidelines to really make sure that providers adhere to this as much as possible. So our peer navigators, we're going to use them to counsel patients on ED alt techniques. And at the bedside, our peer navigators will provide a brief instruction on breathing exercises and meditation techniques. They're also going to assist in arranging outpatient referrals, and as well as continue to provide outpatient linkage to our MAUD clinics. And, that being said, we have a Centers of Excellence addiction clinic, but we also have various clinics across multiple different departments where we have physicians that are trained in addiction medicine as well as their primary specialty. So they could receive like infectious disease and addiction care simultaneously, primary care, addiction simultaneously, et cetera. In addition, our peer navigators are going to continue to address patients' social determinants of health needs. They can help patients apply for medical insurance, apply for the government phones like the Obama phones, so they can facilitate telehealth appointments, provide medication vouchers to help patients actually obtain medications for opiate use disorder and pain medications, provide shelter referrals, and general information about how to apply for government programs. So the clinical decision support systems, so we're going to incorporate this into our electronic medical record. It's going to incorporate our updated pain guidelines, a tailored order set based on pain etiologies. So practicality, this would be like if a patient comes in with a migraine headache, it'll flag the order set for migraines that you can use in order to provide more medications that are consistent with our guidelines. I want to do something similar where there could be dosing guidelines based on the substance history and COW score. So this can help patients receive alternative dosings of buprenorphine. We could talk about micro dosing and macro dosing, and helping providers kind of figure out which dosing scheme works for these patients based on their substance history and COW score. So for instance, if a patient's actively using full opiate agonists, then they can be a candidate for micro dosing. If their COW score is borderline, and they have a highly motivated patient who wants to start buprenorphine quickly, then they could be a candidate for macro dosing. Also, for discharge, I want to create referrals for ongoing pain management, either through the Centers of Addiction Medicine, psychiatry, behavioral therapy, and physical therapy. And I want to update our discharge paperwork to emphasize these outpatient centers that they can receive ongoing treatment for pain and substance use disorders, as well as ongoing mental health needs, and provide ongoing resources for social support services. And I'm hoping if this is within our electronic medical record, we can partner with our hospitals in the surrounding New York area, like, Rutgers, RWJ, or NBI, and potentially share patients' individualized pain care plan through the shared electronic health record.
Do the navigators have access to the EMR?
Yeah, that's how they identify patients. They screen the EMR. They also communicate with physicians through like an Epic chat way.
And
So
they can put notes in the EMR?
yeah, they often put notes in terms of like what they spoke about with patients and what referrals that were made. They're very brief, but it's more like a little progress note. All right. And our third aim is to encourage training on MAUD and pain strategies with the ultimate aim of improving behavioral health outcomes through expanding diversity, equity, inclusion, and accessibility. So we're going to adopt our existing MAUD training that was supported by our second grant to create a module on cultural approaches to pain and potential provider biases. And I'm also going to create another module on pain management strategies using innovative pharmaceutical approaches. So this goes beyond our current ED pain guidelines. So then similarly, we're going to create a new training module on alternative non-pharmacological interventions. So how to educate patients on things that they could feasibly do at the bedside, visual, music therapy, breathing exercises, how to provide community resources, and eventually, as we train our emergency department, extend this training to other hospital departments, like I did with our second SAMHSA grant, where we had residents and students from various departments, both medical and surgical, taking our module. So some of the medications of interest I mentioned earlier, IV buprenorphine. I also want to do research on other partial or biased opiate agonists. We're currently actually buying a nitrous oxide unit within our ED, so hopefully we'll get that within the next month or so. So I'm excited about that. And I also want to do research on using IV magnesium for other causes of pain besides migraines. So, IV buprenorphine, like I mentioned earlier, is rarely given, and if it is given, it's typically in the cases of complicated withdrawal, not necessarily for pain. And I've been giving it for patients who basically have intractable vomiting. They can't take anything sublingually, or they're just too agitated or combative to follow commands and take something sublingually. Like I mentioned earlier, IV bup was approved by the FDA back in 1981 for its primary indication for pain. But, it's been, it's now out of favor, full opiate agonists were used, but I want to sort of bring it back and have it be more of a common pen medication that we can use. And my particular experience with it, and there's other studies that show this as well, that IV buprenorphine is safe. It doesn't have any significant deleterious side effects like respiratory depression or hypotension. I'm currently publishing a case series now where patients received IV buprenorphine for complicated withdrawal, and none of these patients had clinical side effects like hypotension or respiratory depression after getting IV buprenorphine.
Cynthia, do you think your case series provides sufficient support to propose an RCT for intravenous bup?
For intractable vomiting?
Well, you'd have to decide who the target population was based on your research and based on prior research. But I'm thinking, as you're talking about elements of these interventions that might be randomizable in some fashion, either with stepped wedge or in some other way, so that that it would the kind of thing that might let's say warrant NIH funding as a more formal test of an intervention.
I mean, certainly I don't know of any RCTs with IV bup for complicated withdrawal. I imagine it might raise some ethical concerns because what's a comparison group going to receive? So if someone's having, acute severe precipitated withdrawal, you don't give them IV bup.
Well, that's always the question, but it's very interesting because, I mean, in your mind, you don't have equipoise, and yet this is not often, used across most institutions. So every trial has these kind of considerations, and probably a lot of trials get funded that, well, you might wonder whether there really was equipoise, but it's something to think about. And if it's not at an individual level, maybe there's ways that it could be done sort of, through other designs that perhaps comparing cluster randomized, I don't know, but I'm just always thinking about and I'm sure you think about this a lot too, that the pre-post designs give some important information, but if you can figure out how something could be randomized, then you generate stronger evidence.
Yeah. Another issue that I'm thinking also is the patient's ability to give consent.
Yeah.
If I'm giving IV bup, it's usually in the these patients are just under severe distress. They have intractable vomiting or they're delirious. So it's hard to get consent under these situations. But yeah, it's something that I could kind of think about. But perhaps for pain, I think that'd just be an easier, more ethically feasible study.
Right.
Usually patients in pain are still able to consent. They're not in, such distress. And I don't know of any literature using IV bupe as a pain medications in patients who are already taking sublingual bupe.
Mhm. And how is all this, just one other quick question, how is all of this in your mind affected by the high prevalence and potency of fentanyl in the drug environment? How does that change the management?
I think because of fentanyl, we would probably want to use IV bupe just because, fentanyl is very potent on the opiate receptor, and using buprenorphine as a way to address patients' pain. Buprenorphine is more potent than fentanyl. So I feel like if anything, the fentanyl crisis makes it IV bupe more of a desirable medication, just because we're actually able to treat pain by acting directly on the opiate receptor and offset fentanyl.
This would be a great conversation to have with the RWJB team, Alexis and Michael and the team there, because I wonder what they're thinking about this. Danielle likes this idea. And I don't know if I guess we don't still have Lewis, but it would take a lot of thinking, but it does look like something that could be tested in, sort of across sites.
No, for sure. Yeah, I think that would be a really feasible project. And it would be safe because we would only give it to patients who are already on sublingual bupe, so we don't have to worry about precipitate withdrawal.
Right.
I also want to look at other medications that are similar to buprenorphine that are been developed in the last decade or so, have similar physiology but slightly different. Other partial agonist and a biased opiate agonist, and these have been developed as a way to help address pain, but they have a reportedly lower adverse effect profile because they don't result in beta arrestin protein development, and the beta arrestin has been linked to the sedation and the respiratory depression. So right now I'm working with a grad student looking at these different partial and biased agonists and seeing in what settings they were studied and used for pain. There's a lot of literature using these medications in like outpatient settings. I want to see if they've ever been studied in the ED population, and especially in a population that has high rates of substance use disorder. Since it's not commonly used in the ED population, the decision whether to use these partial and biased agonists will have to be made after like a thorough review of the both clinical and preclinical data, and really talking to other expert providers and pharmacists who have more experience in using these medications for pain. But it's something that I'm potentially exploring, doing active literature reviews on, to see if this is something that might be worth bringing on in our own hospital formulary. So like I mentioned earlier, nitrous oxide, we're currently buying 2 units now to start using it in our ED. Nitrous oxide has been used for, over a century for pain management. Actually, one of the first physicians who started using nitrous oxide actually developed a substance use problem himself, and he's an anesthesiologist. So there's a history of nitrous oxide within addiction medicine as well. But that being said, nitrous oxide, it's safe, it's commonly used. My son actually just used it last week when he had to have his cavities filled, and he was such a happy, compliant 3-year-old. I was so happy to see him, be able to get his cavities fixed without any issues. It's not commonly used in the ED setting, but it's commonly used in dental clinics and operating rooms. But I think it really should be used in the ED setting more and more because it has several properties that make it a very desirable agent. It's very similar to ketamine. It has both analgesic and anesthetic properties. So that's a very, ideal thing in that we also don't have to worry about respiratory issues or cardiac issues when we use nitrous oxide. It can be delivered in a hallway area, in an urgent care setting. Patients don't require cardiac monitoring. They can drive immediately afterwards. So it's safe as long as you also administer oxygen at the same time. It's safe up into the 70-30 ratio of nitrous oxide and oxygen.
How long is it safe to keep someone on inhaled NO in this kind of a setting?
Usually it's no more than 30 minutes.
Okay.
Other things that you have to think about, I didn't mention here, but you have to worry about people who have compartment pressure issues. So if they have like an ear infection, otitis media, if they have a collapsed lung, pneumothorax, you shouldn't use nitrous oxide in these populations. But we'll just have to, I think, educate and train our
So
physicians.
this might be a way of like getting through a painful procedure.
Exactly.
So, yeah.
Yeah. And another thing I also imagine it being used for is breaking the cycle of pain. I think a lot of time patients are in pain and they're, unless you get them out like a migraine, unless you can get them out of that cycle, it like abortive agent. So it could be used in addition to procedures for other causes of pain, that's not based on procedures. That could be more intrinsic causes of pain. If they've failed other modalities. So if patients, have failed like our standard multimodal analgesia, maybe we consider nitrous oxide for them, just to kind of get them out of their cycle of pain. IV magnesium. It's in our pain guidelines. We often use it for, non-pain related issues like arrhythmias, electrolyte disturbances, has vasodilation properties. So it's useful for asthma and preeclampsia. And it's in our guidelines for migraines, but it's not routinely used in other painful diagnoses. But there's more and more literature, even randomized controlled trials looking at IV magnesium for other causes of pain. It's through its action on the NMDA antagonist, similar to ketamine. And for similar reasons, it's also studied in alcohol withdrawal treatment. So it's relatively safe medication. It's not addicting. So I'm going to do more literature searches and trying to see if we can use IV magnesium in other painful conditions besides migraines. And then lastly, virtual reality. Like I mentioned before, sometimes I do this on my own and give somebody my phone so they can watch YouTube videos while I'm doing something painful to them. And we found, there's past literature that shows that virtual reality is an effective tool for both acute and chronic pain management. It decreases the utilization of opioids. It improves pain scores, and also has objective proof that it mitigates patients' pain when there's like functional brain imaging assessments when patients are using virtual reality during a painful procedure. One of our medical toxicologists at our hospital has an IRB using virtual reality. So we're going to purchase some Google lenses that can be paired with a smartphone so they can do virtual reality. And then music therapy. So by delivering music therapy via mobile devices, we can use automated discovery algorithms to generate self-managed music lists. And we can use this to modulate pain and decrease opiate use. And we can use this to address patients' various cultural and language preferences. And there's a lot of basic science literature that shows that music augments the positive reward pathways. It helps reinforce healthy engagement with various disease states. And it's been shown to decrease postoperative pain, perioperative opioid use, and also reduce stress both perioperatively and in intubated patients, as well as before painful procedures. And it also has been studied in the ED population in patients with substance use disorders. And our department chair, Lewis Nelson, has an IRB already in place looking at music therapy for our patient population. I actually am working with several medical students in submitting a Rutgers grant to improve music therapy for outpatients by setting up the monthly jam sessions, using a music therapist to help kind of patients have more engagement with their community and have these monthly music sessions. And we're gonna approach patients who are engaged with our Centers of Excellence Addiction Clinic, and our peer navigators are going to recruit patients from our ED to join these monthly like jam sessions. I kind of see it as like an overall like improvement in wellness as well. You know, we can invite our musically inclined medical students, residents, faculty, if they'd like to, you know, be part of these jam sessions. And we'll use grant funding to hire a music therapist to actually create like a music therapy curriculum. And then for our referrals, I mentioned earlier cognitive behavioral therapy and meditation therapy. It's very hard to do in the ED just because of the noise, the chaos, the crowding issues. But at least discussing these modalities with patients, the peer navigators can help patients be linked to community resources. And similarly, we can use telehealth to have patients get ongoing ED alt referrals, whether it's through yoga, meditation, CBD. And we'll be using our telehealth services by using one of SAMHSA's evidence-based profile model, telehealth for the treatment of serious mental health illness and substance use disorders. Our primary data tool would be the mandatory tool that SAMHSA requires. It's a GPRA data collection tool. It collects a lot of information about patients' substance use history, their clinical outcomes, their mental health issues, ongoing social determinants of health needs.
Cynthia, if you have any sort of remaining slides that are really key, you probably should jump to them because we're going to lose people.
Oh yeah, so these are the last two slides. I don't want to bombard you guys with my data collection tools, but we're going to be doing both prospective data collection, retrospective data collection, and this is our team. So we have a good group. We have our previous peer navigator, who's now the program manager. She's been with us for almost 6 years. Our ED collaborators, we have several medical toxicologists involved. We have a clinical informatics expert. My husband's in this because he's also an ED faculty here. He does ultrasound and nerve block. Kamina Dubai, she was recently hired. She has a lot of rich experience addressing cultural biasness. Tim Saddy, our EMS medical director, and our PharmD, Jackie. You know, we'll be working a lot with the medical students and residents too. And I also want to thank Nina Cooperman, Stephen Crystal, and Daniel Dick, both for their previous help in developing our grant applications and for our future support. You know, we just got started this past month, so I'm sure I'll be reaching out to you all more as we're getting our hands more dirty with the data.
That's awesome. Please do. And I wish we had time to chat about future where some of this might lead for NIH funding possibilities, but hopefully we can have that conversation as we go forward.
Yeah, for sure. You know, maybe the IV butte for pain would be a good example.
I love that. Let's find a time to talk about it.
All right. All right.
It might be something that the NIDA Clinical Trials Network would be interested in.
Yeah, maybe.
But you might if it's a new enough idea, you might want to get something like an R34 to have the proof of feasibility, and that would be a grant that you could get that would be decent size, but not leading up to the more definitive trial.
Do you think this is something that should be done after we get our IV buprenorphine guidelines out.
Yeah, I think that's awesome.
Okay. I'm just wondering if it's something that should be done, like maybe after we get ourselves more comfortable using IV buprenorphine.
Absolutely. Absolutely.
Okay.
Then you could share those early results with folks in RWJB system and look at sort of ways to test it over more than one institution.
Yeah, that's a good idea. Thank you so much.
Awesome.
Thank you
Thank
so much,
you.
Dr. Santos, for a great presentation. We really appreciate it.
All right. Thank you all.
All right.
Take care.
Talk soon.
Bye-bye.